Okay, it's a couple minutes after 11, so I'm going to go on ahead and get started. So I want to thank everybody for joining us this morning for the Assisting Clients with Complex Medical Needs Distance Learning event. This session is the second in a four-part Outreach and Enrollment Distance Learning series, a collaboration between Community Health Association of Mountain and Plains States, or CHAMPS, and Colorado Community Health Network, or CCHN. My name is Sophie Hagberg, and I'm the Outreach and Enrollment Coordinator at CHAMPS. You can find more about this series, as well as the dates and times for upcoming events, on the CHAMPS Distance Learning page. All of the distance learning events in this series will take place once a month on Thursdays at 11 a.m. Mountain Time or 12 p.m. Central Time from June through September of 2016. The next event in this series, Engagement and Issue Advocacy for O&E Staff, will take place on Thursday, August 18th at 11 a.m. Mountain Time or 12 p.m. Central Time. CHAMPS is your Region 8 primary care association dedicated to supporting all Region 8 federally funded community, migrant, and homeless health centers so we can better serve our patients and communities. For more information about CHAMPS program and services, please visit www.champsonline.org, and the address is up on your screen. Colorado Community Health Network, or CCHN, represents Colorado's 20 community health centers that together are the backbone of the primary health care safety net in Colorado. CCHN is committed to educating policymakers and stakeholders about the unique needs of CHCs and their patients, providing resources to ensure CHCs are strong organizations and support CHCs in maintaining the highest quality care. For more information about CCHN, please visit www.cchn.org, and the address is also up on your screen. So now I'd like to introduce our speaker, Sarah Lewick. Sarah joined the Center, or the Center on Budget and Policy Priorities, in November 2008 as a senior policy analyst. She works on issues related to health reform implementation, specifically health insurance exchanges and private market reforms included in the Affordable Care Act. She's also a consumer representative to the National Association of Insurance Commissioners. Before joining the center, Sarah was a reporter for 9 years in the Washington Bureau of the Wall Street Journal. For much of that time, she wrote about health policy, including Medicare prescription drug legislation, state and federal proposals to modify Medicaid, and the efforts of healthcare companies to influence policy changes. She later covered Congress, writing about tax policy and immigration and economic recovery legislation, as well as House and Senate election campaigns. A native of Des Moines, Iowa, she graduated from the University of Iowa in Iowa City with a BA in Spanish. So Sarah, I'm now going to turn it over to you.
Thank you so much, Sophie. Thanks to everybody who's on the webinar today. I look forward to sharing what I have in my presentation, and then also hearing any questions that you may have as well. So what I'm going to do today is talk about, kind of divided up my presentation into 4 parts. First, I'm going to talk about the basic components of health insurance plans on the marketplaces. Then I'm going to talk about cost sharing reductions, which are really important assistance for people that have low incomes that are available through the marketplace. And third part is going to be finding information about plans, like what are some ways that you can track down the details that might be important to people with complex medical needs. And then fourth, kind of a walkthrough of the process of helping people with a couple of examples of clients that have medical conditions that will need some special attention as they look at different types of health plans that are available. And then at the end, I will be leaving time for questions, so hopefully anything that I've missed or that you find confusing, we can try to work out then. All right, so to kick it off, 1 second here. A very important piece of the puzzle when we're talking about health insurance, obviously, is premiums as well as cost-sharing charges. So premiums are what the people pay to get the plan, and the cost-sharing charges are what they pay when they use the benefits covered by the plan. And I think that's often what people that are looking at health plans are mostly thinking about. But for a person with complex medical needs, another really important piece of the puzzle is what the plan covers. So covered benefits of all the marketplace plans includes essential health benefits, that's preventive services, as well as a variety of other kind of general categories, everything you could think of in terms of hospital care and outpatient care. Additional benefits are possible in the qualified health plans, and then there's a prescription drug formulary, which is a list of covered medications. Another really important piece is the provider network under the plan. So insurers contract with the physicians, hospitals, and other professionals to provide services to people. The plans vary in terms of how broad their provider networks are, and some don't even provide any coverage outside of their network, so that's something important as well. For cost sharing, I'm not going to spend a ton of time on this. I think everybody on the call probably knows these terms, but we're going to be talking a little bit about cost sharing and its impact on people when they have one of these plans. So I'll just leave the definitions up there for a moment. And then a really important piece is also the maximum out-of-pocket limit. So there's sometimes some misconceptions about this. People get it confused kind of amid all of the different types of cost sharing there are. But this is a cap on what the enrollee pays in cost sharing charges each year. And it applies to in-network services and not out-of-network care, and that can be really important too. So it's a very important protection for an enrollee, but it only applies to the care that they get in-network. And a question we get a lot, so I just want to put it out there, is that it isn't an amount that the patient has to spend during the year under the plan. It is the limit on what they would need to spend when they get services. And as you can see at the box on the bottom of the slide, there are lower out-of-pocket limits for people at lower income levels, and we'll talk more about that in a moment. So I think everybody's probably familiar with the metal levels in the marketplace, bronze, silver, and gold. And I'm not going to talk about actuarial value, but suffice it to say those metal levels are basically set based on a complicated insurance formula about how comprehensive the plans are. Basically the difference that we're talking about when we're talking about bronze versus silver versus gold is what the out-of-pocket charges are going to be for the enrollee. So the lower metal levels, bronze for example, has higher out-of-pocket charges for the enrollee, such as a deductible and the out-of-pocket limit, than the more precious metal like gold, which would have lower deductible out-of-pocket limit for the enrollee. And one other thing I just want to draw your attention to right there is with the primary care visit row, something that you might see in qualified health plans a lot, is that some limited number of visits, primary care visit or other types of visits, may be available under a plan for a copayment even before a person reaches their deductible. So traditionally deductibles apply to everything. But now we're seeing a lot more cases where some things that a person might need are accessible to that person even when they haven't spent their deductible yet for the year. So you could go in and get under the bronze plan, Plan B that we see on this slide, 2 primary care visits for a $40 copayment, and then you would be starting to pay your deductible after that point. This is a slide to show the differences in the way in-network and out-of-network cost sharing might work under various types of plans. So for example, you can see Plan A, which is the top 2 rows. In-network and out-of-network services simply have a different set of cost sharing charges, so different deductibles, different out-of-pocket limits, et cetera, with the in-network charges being lower for the enrollee than the out-of-network charges. The second plan, you can see that there's in-network charges there listed, but there's no out-of-network coverage at all under this plan. So if a person that was enrolled in this plan used a provider out-of-network, they would have to bear the cost of that on their own. And then Plan C, it's a more complicated design. It's a tiered network plan, but it's something that does exist in the marketplace, so it's worth knowing about. That's basically a situation where there's a certain set of providers that are Tier 1, there's another set that are Tier 2, and there's another set that are Tier 3, and there's basically graduated cost sharing depending upon what tier you're in. So I think ideally the enrollee is going to want to try to use in-network as much as possible. If they're in a tiered plan, they're going to want to try to be in Tier 1 as much as possible. Another important thing to remember with the network issue is that when a person goes out of network, there's sort of the risk of balance billing. That means that a provider's charge might be higher than what the plan pays. So in a case that the enrollee goes out of network, they would owe that extra money potentially. And so that's kind of an extra risk that people take when they see an out-of-network provider, and something they need to be aware of if at all possible to stay in network. Another really important component of a health plan for a person with various medical needs is going to be the medications that they may use regularly, or the medications they may think they're going to need during the course of the year. So when we're talking about prescription drug formularies, there's two key issues. The first one is whether a drug is even on a plan's formulary. So ideally, yes, you do want the drug to be on the formulary. You want to try to get a prescription for drugs that are on the formulary, or switch to them if at all possible, if it's something that you can do with your doctor. And then the second component is, what is the cost sharing that the plan requires the enrollee to pay for that drug, right? So the formulary is usually divided up into tiers, just like the provider network that we just looked at. So there could be Tier 1 drugs that would be cheaper than Tier 3 drugs, and the plans will be setting different charges, either co-payments or co-insurance for each of those tiers. Often there are specialty tiers for very expensive drugs, and those can be very expensive for patients that need to take those medications. On this slide, you can see it's a comparison between two different plans and the way that those plans treat the two drugs that we have here. So there's drug X, which under Plan A has a $10 copay, and under Plan B, it's under Tier 2, it has a $40 copay with having to pay the deductible. Drug Y, on the other hand, is not covered under Plan A, so the cost is very, very high. The person would have to pay it out of pocket. And then Tier 3, drug Y is a tier 3 drug in Plan B, so that means there's there's still a significant cost, but it's much lower than the person would be under Plan A. So this is just to show that the drug formulary really matters, making sure that drugs are covered that the person needs, and also understanding what the cost sharing is going to be for those drugs. Next, I'm going to talk about cost sharing reductions. I know this is really important for lower income populations that you are serving. So we talked about bronze, silver, and gold, but for people that are under 250% of poverty, there's a special assistance with cost sharing that's available if they enroll in a silver plan. So you have to enroll in the silver plan to get this assistance, and the way that it's provided is by the insurer actually has its standard silver plan, and it then adjusts it. So the person automatically gets lower deductible, lower out-of-pocket cap, and that sort of thing. So here you can see on this slide that if you're over 250% of the poverty level, you don't get CSR in the standard silver plan, and your deductible is around $6,850 in this example. As your income goes lower, you could get access to lower, out-of-pocket. That was out-of-pocket. You can get access to lower out-of-pocket amount all the way down to $2,250. And this is just a slide to show how a plan sort of is transformed by the cost sharing reduction, and you can just see there that it's quite a significant difference in terms of what the enrollee would need to pay. So if they were in Plan A without a cost sharing reduction, which is the first column that you see there, they would have a $4,500 deductible, and then that would decrease for a person that's under 150% of poverty down to $250. It's still obviously a significant deductible for a person at that low of an income, but it's much more possible that they're going to be able to access the care they need with that sort of cost sharing. You can see also that the co-payments for services are reduced as the person's income is lower. And for each of the drugs there, you can see there in the primary care and specialist visits, there's lower. So that's good news for people with complex medical needs who may also have low incomes, because it can make it easier to afford the services that they receive. So even if a person gets a cost sharing reduction, they are still going to see variation in the cost sharing they would have to pay under different types of plans. So that's something to be aware of. It's not like they get a cost sharing reduction and the charges are going to look the same to them under any plan that they would get, and there may be differences that impact how affordable different services are for them. So it's worth paying attention to that detail. Here you can see Plan A and Plan B are both have an actuarial value of 94%, so they're CSR plans at the most generous CSR level for people that are low income. And Plan A has a $250 deductible, while Plan B has a $100 deductible, so that's quite a big difference. And then the out-of-pocket limits are also quite different. So a person in Plan A could end up having to spend as much as $2,250 if they had very, very expensive medical needs during the course of the year, and the person in Plan B would pay no more than $500 out of pocket for the whole year for the in-network care that they receive. In addition to cost-sharing reductions for low-income people generally who are getting that premium tax credit, there's also a special set of assistance for people who are American Indians and Alaska Natives. So this group of people, if they qualify, they can enroll or change marketplace plans each month. That's one significant extra protection for this population. But even more significantly, for people who are between the poverty level and 300% of the poverty level who qualify for premium tax credits, they can get zero cost-sharing plans. So that's very significant because they pay no deductibles, co-payments, or other cost-sharing charges when they use medical care. And from what we can tell, and some of you may know this better than me, but it looks like out-of-network care is also available with zero cost sharing, so that can be very, very helpful for people who need to make sure they can access a variety of providers. For people with incomes that are below the poverty level or above 300% of the poverty level, they can get a limited cost plan. And under that type of plan, who are members of federally recognized tribes and Alaska Native Claims Settlement Act shareholders, those enrollees in the limited cost-sharing plans can pay no cost-sharing charges if they receive services from an Indian healthcare provider or from another provider if referred from an Indian healthcare provider. So how do we find information about qualified health plans that will be important for people with complex medical needs? One really important tool that's available is called the Summary of Benefits and Coverage, or SBC. This is a form that was created by the Health Reform Law. And it really is available for any plan, so anybody that has employer-sponsored coverage should either have received these or can ask for them at any time. And then, it lets you compare plans in a standard way because the form has all of the same information requirements. So insurers put all the same information in there for various plans. It looks the same, basically. They differ in length from one plan to another, but the boxes are all the same and the formatting is the same. So it's nice to be able to access these forms for various plans, sometimes lay them out side by side and really kind of look at what one plan looks like compared to another. The information in the SBC is pretty basic. When we're thinking about populations with complex medical needs, you're going to be able to get some important information about cost sharing requirements, as well as like what benefits are covered and that sort of thing. You can also get links to the provider directory and the formulary that applies to the plan. So that's helpful research as well. But if somebody has complex specific medical needs, you may not necessarily find it on this form, and you may need to seek out other sources of information for that, which we'll talk a little bit more in a minute. The SBC itself can be found on the Marketplace or Exchange website, and as I said, insurers are required to provide this. So if for some reason you can't find it, you can either look on the insurer website, they may have it posted there, or you can call the insurer and get it. It might be even worth something kind of pulling ahead of time if you have the chance to do that before open enrollment starts and getting familiar a little bit with what's available under various plans. So on the first page, if you can see it, there's bolded numbers that I think you can probably see pretty well that talk about major cost-sharing aspects of the plan. On the second page, you start to see what common medical events a person might need and what they cost, and then limits and exclusions that might be in play as well. You can see on this slide, I think, that this is a really kind of an important feature that you might be able to find on the SBC that could be important to some of your clients. You can find information about visit limits for various things. So you may have some services, especially things like physical therapy, rehab, skilled nursing care, that somebody need, but the plans can place limits on in terms of how many sessions of that therapy or service that person can generally get during the course of the year, and the SBC should have that information in the last column, so that can be very helpful. Those limits do vary from plan to plan, so they can be significant and an important thing if somebody knows that's something that they're going to want to use. Another good thing to pay attention to in the SBC is a box that's in every one of the forms that shows excluded services, so services the plan does not cover, and then additional covered services that are like not part of the essential health benefits but that the plan has added. So that would be where you might look and see that a plan offers, in this case, hearing aids or bariatric surgery, but another plan says no dental care for adults and no hearing aids for adults. So it's just worth looking at that and seeing if any of the services that a particular client has mentioned is in either of those boxes. So how do we what's the approach that we can use to help a person make sense of all the information that we can help them collect about the plan and actually kind of feed it into the process about what plan they're going to actually want to buy? The first thing I think is to check in with the consumer and ask them some questions about what is important to them. So kind of a general way of approaching it is, what are their priorities for healthcare coverage? Are they, for example, really concerned about making sure that the premium is low? Are they worried about making that premium payment every month? Or are they perhaps more concerned about having a plan that has a big deductible or a big out-of-pocket cap? And that would be a very legitimate thing for somebody with complex medical needs to be concerned about. They may very well know that they're going to have lots of needs for expensive services, and they may not. They may be more comfortable making sure that those out-of-pocket costs are as low as possible, so that they're as protected as they can be. A second question to ask is, what services and healthcare providers does the person expect to use? Do they think they might mainly get outpatient services, say outpatient therapy if they have mental health needs? Do they think they may need to be admitted to an inpatient facility, which is a whole other set of cost sharing that you would want to pay attention to when you're thinking about what plans to choose, because some do have higher out-of-pocket costs for inpatient. Generally, that's what you'll see, and you want to make sure that it's not out of bounds if the person thinks they might be hospitalized. And then what types of specialists might the person need? Are there conditions that they have that make certain types of specialists really likely for them to see during the year? Are there certain types of lab tests that they typically get? Are they getting ongoing therapy, like physical therapy, for example, that they would want to make sure is covered well enough under the plan? The third kind of question to ask is, does the person want to continue seeing one or more specific healthcare providers? So if somebody's been dealing with complex medical needs, they may have doctors and other providers that they're very attached to, health centers or clinics that they really want to make sure are in a plan's network. So that is the point when you want to look at the provider directory and really investigate and see if you can make sure that as many of their providers are in the network of the plan as possible. And then they can choose a plan that has as many of those providers as possible. And it may involve prioritizing. They may not be able to get every single one of the specialists or the physicians or other providers that they see or that they have seen or that they might see, but some may be more important to them than others to make sure that they're definitely in network. And then the last question is, what prescription drugs does a person think that they might take during the rest of the year? And are there some that they take on a monthly basis or very regularly, because those would be very important to make sure that they're on the formulary and that they don't have unreasonably high out-of-pocket costs and that the person will be able to access them under the plan that they decide to buy. So a really helpful tool that we've used here is a worksheet, a plan comparison worksheet. It's just a blank form, and we're going to make sure that you get a link to it so you can use it if you decide this is the route you want to take. It really just helps to put all the information that you might collect about various plan options in one place so that it can kind of be a reference tool for the person and easier for you as you're looking through the SBC or other plan documents and trying to pull out, what is the deductible for each of these plans, what are the copayments for generic drugs, or what are the drugs that this person needs. All of that information can kind of be collected and pulled together on this sheet. So now let's go into a little bit of a couple of examples that will, I think, help illustrate how this process might work. So in this example, it's related to zero cost sharing plans and a couple of concepts that I've mentioned. This is Gabby, and she lives with her son, Henry, in Billings, Montana, and her income is around $43,000 a year. She's eligible for a premium tax credit of $155 a month for a plan that will cover both her and Henry. And she and her son are both members of a federally recognized American Indian tribe, so they are both eligible for zero cost sharing plan. Now, Gabby has some health concerns. Henry has asthma, and she herself has had depression and chronic back pain. Both are things that she might need treatment for during the time that she's going to be covered by this plan. So how can we help Gabby look for a plan? So because she's eligible for zero cost sharing plans, the difference between the different metal levels, bronze, silver, gold, etc., generally appears for her. So she can get the tax credit and get a bronze plan, for example, for a fairly affordable cost, but then have a cost sharing charges reduced to zero. So she doesn't have to buy a silver plan to get that. So she can pick kind of a lower premium option and still get really good cost sharing protections because of that zero cost sharing element. However, it's still important for her to think about other differences other than cost sharing when she's thinking about different options that are available. Some of the things she might look at: premium cost, provider network. As I said, out-of-network charges should still be zero under the zero cost sharing plan. However, there is the potential for balanced billing if somebody goes out of network. So that's something to just be aware of. Our understanding is also that if providers are out of network on a plan, it could be harder for the person with a zero cost sharing plan to get an appointment. So it might be worth paying attention to what is in the provider network as she's looking. Visit limits, as I mentioned, that could be important for her if she's going to get mental health services or if she's going to get any physical therapy or other services for her back pain. And then additional covered benefits, or maybe the access to an adult dental benefit or vision benefit is something to look out for. If it's in the plan and it's zero cost sharing, that can be helpful to her. So here are 3 bronze plans that we've pulled that Gabby could possibly choose from. You can see that 2 are from Blue Cross Blue Shield and 1 is the co-op. And they have different premium levels. That's the bottom row of this chart, $208 a month. This is after the tax credit that Gabby can receive for option 1. For option 2, she would pay $243 a month in premiums, and for option 3, she would pay $218 a month in premiums. So there is some differences there that could be important to her as she's trying to decide what's affordable. So one thing we could look at here for her is the SBC, and you can see that, I think, with the blue form on the slide. That's just a little close-up of the fact that, mental and behavioral health outpatient and inpatient services are covered, and there are no charge for in-network providers for Gabby because of the zero cost sharing plan, and there are no charge for out-of-network providers. You can see that there are some limitations and exceptions written here. It looks like if she needs intensive outpatient treatment, she may need to get pre-authorization. There's other pre-authorization requirements, and she needs to be hospitalized on an inpatient basis. So that's just something that's there and good to be aware of, because it can help somebody understand how other kind of barriers that there might be to getting services or other steps they might have to go through in order to get those services. And we see here on this next slide the co-op plan. similarly to the two blue plans that we just looked at, has no charge for the in-network and out-of-network providers. It also helpfully notes here no charge if you use an Indian Health Service provider. That's important too. She qualifies for that as well. And then in the box on limitations and exceptions, there's nothing there. And that might be helpful to know that perhaps this plan is actually not requiring pre-authorization or other kind of utilization management things that were on the Blues plan SPC, but I think I would take it with a grain of salt. I wouldn't be 100% certain that, first of all, that everything in the SPC is absolutely correct, but also that, especially on a detail like this, it could very well be that the insurer just didn't put all of those limitations and exceptions. So it might be worth, if that's a really important component, to look at other plan documents and just see if pre-authorization applies to those services. All right, so let's take the worksheet here and see, start populating the worksheet and the information that we just found. You can see the boxes are filled in for the mental outpatient care, mental health outpatient care, mental health inpatient care, the premiums. And then down at the bottom, we've put psychiatry here because maybe she will need to see it. She doesn't have a psychiatrist now. She's not getting treatment for depression right now, but something she might want to get treatment for or need to get treatment for. So we've just noted here what the plan networks look like for these various options. So with option 1, by doing a provider network search on the plan website, you can see that there's 19 specialists in 20 miles with the first plan and 28 specialists in 20 miles with the second plan, and quite a lot fewer specialists with the third plan option. So it's just worth noting that it looks like for psychiatry at least, those first two plans have a broader network. So some other considerations here. This is basically the worksheet populated with a lot of other information. I'm not going back and forth with the SBC because it can get a little tedious. But these are just some other important things that it's worth noting. So it says here, for example, that the Dr. Castile at the Billings Clinic is covered. That's a provider that Gabby has been using. She's been taking Henry there in this example. And she expresses as we were talking to her, I think that a lot of the things that Henry's going to need for his asthma are kind of a high priority for her. So she really would like him to be able to continue to go to the same doctor. And it's pretty well controlled, but she's also concerned that potentially he might need more specialist care. So you can see at the very bottom here, I think, that pediatric pulmonologists are another search that we did, and we can see that there's one specialist under the first plan option within 20 miles, and there's 2 specialists within 20 miles under the second option, and 1 within 5 miles under the co-op. So that's pretty consistent from plan to plan. There's a closer one, it looks like, with the co-op, but that's something that Gabby thinks she might need potentially. All the plans cover Henry's asthma drug, which is great, and they all appear to have the same cost sharing from what it's not on the sheet, but we looked at it and it looked like they were all the same, so that's interesting to know as well. If she decides to get chiropractic care, say for her back pain during the year, first 2 plans each have 10 visits per year limits. She can't generally get more than 10 visits a year for that, but the third plan has 20 visit limits, so that's another difference to be aware of. I think in general, it's clear that she really does want to make sure that this doctor is a network, and that's only an option for her with the first 2 plans. And then with this provider, Lame Deer Health Center, that's actually an Indian Health Services provider. So even though it says it's not in this plan's network, Gabby can go to that provider, and for essential health benefit services that she receives, there should be no charge. So that's significant as well. That's another point of access for her. It's a bit far from her home, but it is another thing that she might do if she's going that way. All right, so ultimately I think she's probably going to go with the first plan, option 1. The reason being it's a low premium among the options that we have here. It provides a doctor that she sees, or that her son sees. His drug is covered. It seems to have pretty good access in its work to various types of specialists. And she can, even though it says a no here by by the health center, she can still use that because she is a member of a federally recognized tribe. All right, let's go on to our next example of managing chronic illnesses. So this is Doug. He lives in Cheyenne, Wyoming, and his income is around $22,000 a year. He gets a tax credit of $403 a month plus cost sharing reductions. He has diabetes and he has coronary heart disease. And he indicates that he travels for work, sometimes to Colorado and Nebraska, and is interested in possibly a plan that would let him get care if he's on the road. So how can we help Doug shop for a plan? In Wyoming, there's only one carrier for the marketplace. It's Blue Cross and Blue Shield. And to help manage his multiple chronic conditions, he's going to need to look carefully at the cost and coverage of various benefits, prescriptions, and services. Doug is eligible for cost sharing reductions, so a silver plan will help reduce his out-of-pocket costs when he uses coverage. And because he travels to other states, he's going to be looking for out-of-network or multi-state coverage. So some specific plan areas to look at for somebody like Doug would be coverage of diabetes medication, services, and supplies, coverage of heart disease medicine that he takes, and access to out-of-network or multi-state coverage. All right. So the options for Doug are here. You can see that the premiums take into account the premium credit, the amounts that you see on your screen for each of these plan options. The cost sharing charges that you see for the deductible and the out-of-pocket maximum, those also take into account the cost sharing reductions that Doug is eligible for because he's getting, these are all silver plans, and he's getting a cost sharing reduction that makes his silver plan an 87% actuarial value instead of a 70% actuarial value, so he has lower deductibles and other charges compared to the standard silver plan. The second kind of bottom half of this slide shows how we could fill in the worksheet for Doug on these various plan options, what it costs out of pocket if he wants to see his primary care provider, for example, and what different types of drug tiers in the formulary would cost on these various plans. So for example, it's worth looking at the primary care provider visit. So we have $25, it looks like, for the first 6 visits that he could get from a primary care provider under the first plan, and then $20 copayments for each of the first 6 visits under option 2. So an interesting model, we talked about it before, where he doesn't have to pay the deductible up front for those sorts of visits. He just pays the copayment, and then and he can get those services, that limited number. You can see that the generic drugs, as always, are cheapest out of pocket for Doug. If he can manage to get generic drugs for the things that he needs, that would probably be the most affordable. And then the more kind of co-insurance amounts that you see for things, the more it's just kind of worth being aware that can be quite costly. It doesn't tell you exactly what you're going to pay, right? It depends on what the cost of the drug is. So it's a little bit more risky for a patient, especially somebody who has complex medical needs. But if you can get copayments, I think generally that's going to be better and more predictable for people. All right, so to Doug's question about whether he could access health care while he's traveling, all of these plans do have out-of-network coverage, but that is a separate set of cost sharing, as we discussed. And the cost sharing reductions don't apply to out-of-network care, so that's really significant. He probably has a very, very high deductible, probably unaffordable for him at his income level. So the risk of him having to pay a lot of money out of pocket is pretty high if he goes out-of-network. So it's just worth knowing that he's going to have to be careful if he decides that. And then I should have also mentioned that the formularies for these plans, because they're all from the same carrier, and the provider networks are all the same. So one thing we can look at for Doug is diabetes care. What are the things that he's going to need to manage his diabetes, and are they covered, and at what cost to him under the various plans? So in terms of diabetes supplies, we're talking about things like test strips or other ways of monitoring blood sugar. That's going to be very important to a person with diabetes. They can cost a lot of money. They really add up. They're low amounts of money, but it really adds up because they have to use them all the time. So it's really important to check in, make sure that the plan covers that, and to be aware of what it costs out of pocket. We were able to find this information in the formulary. It's not always in the formulary when we're talking about diabetic testing supplies, but that's where we found it, and I think that's probably a good first step is to check there. Another thing Doug's going to need is insulin, and we put that in there too, and just we did a quick search on kind of what's on the formulary, what tiers is he on. But keep in mind, since the formulary is the same for each of these plans, he's not really choosing based on this for each plan. He's just basically kind of you're helping him get a sense of what is covered under the plans, what is sort of the cost that he's going to pay. He may need a specialist, right, like an endocrinologist during the course of the year. Unfortunately, when we do the search, there's 0 specialists in 50 miles. So that is significant to know, but it's going to require some extra steps if he does end up needing that sort of specialist to get access to that. I think another important resource I wanted to make sure you saw is that this is at the end of the SBC, so that form that we talked about before, that standard comparison form. These are called coverage facts examples, I think, and it's basically a scenario, and it happens to be for somebody who has type 2 diabetes, somebody very much like Doug. And this was included in the SVC because it's sort of like a nutrition label on like your bottle of ketchup or something that tells you on an apples to apples basis how many calories are in this food and how much fat versus this other one. So this is sort of along those same lines, but it's obviously a much more complex thing because we're talking about healthcare. So when you look at this, the purpose of this, and what you see here are 3 different examples of the same set of services for a diabetic person under these 3 different plans that we're looking at for Doug, and what does the plan pay for that same set of services versus what the enrollee pays for that same set of services. Now, it's really important to remember that just because Doug has diabetes and this example deals with somebody that has diabetes, it doesn't mean that he's going to pay this much out of pocket or this is exactly what his experience is going to be. What it really is meant to be is sort of a way of comparing relative costs from plan to plan. So in general, it looks like a person with diabetes in this scenario that we've run that's on the SVC is going to pay less out of pocket for the plan in the middle, so just over $1,000. And that kind of makes sense because it has a lower deductible and out-of-pocket cap than the one on the left. So that's really interesting, I think, just to know that how this plan treats diabetes, the patient in general looks to be spending somewhat less money in the center option. The other coverage example you can find in the SBC has to do with having a baby. So it's just a reference tool. I wouldn't buy a plan based on what it says in this coverage facts example. It's just a way of getting a sense of how much cost burden various plans generally put on patients. All right, so back to the worksheet for Doug. We can see here we put some information in related to the care of his heart disease. So near the bottom of the screen, you can see that he takes a blood pressure medication, and it is on the formulary. It's on tier 3, so it's not going to be. It's going to be, a co-payment, or sorry, co-insurance for him. And then we looked into a special appointment to see with a cardiovascular disease specialist, and we can see that these plans all have 4 specialists and 50 miles of that type. So I think at the end of the day, Doug is going to have to consider both of the medical conditions that he has, as well as other health needs that he could potentially have during the course of the year. It looks like the diabetes care and services that he needs to manage that illness, those are going to be pretty costly. So it's worth paying attention to how the plan covers those things and what his out-of-pocket costs would be. I think that for Doug, he's going to want to keep the out-of-pocket costs low. That's very important to him. But it's really, I think, a trade-off then between probably Plan 1 and Plan 2, just because the premiums are lower, and they have these separate drug deductibles, which can be helpful. And then they have a low out-of-pocket cap, so $1,000 and $1,500. And actually, for somebody like Doug, it might be worth paying special attention to the out-of-pocket cap. They may very well, with multiple chronic conditions, reach that cap during the course of the year, so getting the lower one is probably a really helpful protection. But I think it's really going to be up to Doug as to whether he'd rather pay a little, like a decent amount more premiums every month, $130 per month versus $97 per month with this tax credit, in order to get the extra cost sharing protections that are under option 2. So it's really just a trade-off, and he could decide to do either one. All right, and the last thing is kind of a wrap-up. Some key takeaways when you're doing this sort of work for people. I think cost considerations are likely the most important as a headline matter, right? The premiums and the out-of-pocket costs are really what people have to think about very carefully, and balancing the two, as Doug just had to do. A critical part of the process is thinking through what the person thinks they or their family are going to need during the course of the coming year, or if they're joining mid-year, what they're going to need for the rest of that period. It's likely that a person with complex health needs will have to prioritize some things over others when deciding which plan to choose. In other words, there's not a perfect plan probably, and they're going to have to decide, is it more important for me to be able to see this doctor or that doctor? Is it going to be more important for me to have a broader network in case I need healthcare services that I may or may not expect? Or is it more important for me to have the drugs that I know that I'm going to take on the formulary and with a copayment that I feel I can afford? Those sorts of trade-offs are going to have to be made by anybody with multiple health needs, or perhaps who have different family members with different health needs. And finally, helping somebody understand the differences between various plan options can help them use their coverage most effectively once they have it. So it's challenging, and as we saw, there's not always a lot of different plan options in some of the places where you all live. There's not a lot of differences between plans in some cases if there's a limited choice of carriers. And even when there is, the person's, like I said, not going to be able to hit every one of those perfectly. However, going through some of those details of the plan, helping the person to understand things about cost sharing and some things about prior authorization or other barriers that they may face can be really helpful, because when they do finally decide what plan that they want, that hopefully will help them understand how to use it. And with that, I will turn it back over to Sophie.
Thank you so much, Sarah. I think now we can kind of open everything up to questions. We have about 10 minutes. So if you have any questions, you can go on ahead and type them into the chat box now. Sarah, we'll just give everybody just a couple minutes to see if there's anybody who has anything.
Great. One thing I can mention, if people are thinking about questions, is in addition to the SBC, there's some other places folks can look if they want to get some plan details. I think one thing is, as I said, the SBCs aren't always perfect. So if there's something that's really important to make some detail that you really want to know about a plan or that the client is asking about, it may be worth calling the insurer directly or having them call the insurer so that they can ask that question or you can ask that question. If they really want to make sure that a particular provider, for example, is in a network, it may be worth that phone call, because the directories of providers are not always perfectly up to date, or they may have errors. And then if somebody has complex medical needs, there may be special details that just aren't that easy to find. And one thing that can be really helpful for consumers is to get the actual plan contract sometimes. It's a lot of legalese and jargon, but there is really good information in there. That's kind of the the source of truth on what is supposed to be covered. So if they want to know about what kinds of prior authorization and things like that apply to various services that may not be on the SVC or may not be in the plan marketing materials, they can ask for the plan contract, and the insurer is supposed to provide it to them.
Awesome. That's a really good piece of advice. I have also found that it's good to check with the insurer directly about drugs as well, too. Sometimes the formularies are not 100% accurate, or at least make sure you're looking at the formularies. Correct me if I'm wrong, don't they vary by plan and
Yes.
level?
Yeah, it's a very good point. So the link on the SBC is supposed to take you directly to the correct formulary, but you're right, Sophie, it may not be right. There have been problems with that in the past, or formularies can change. So it may be worth, again, if the enrollee has a lot of specific things that they're going to need, just doing a double check to see with the insurer, just let me confirm that these are all covered.
Awesome, thank you. Well, it doesn't look we have any questions, so I think we can end a little bit early today. So on behalf of CHAMPS and CCHN, I want to thank you all for joining us this afternoon. When you close this window, a survey will open up on your computer. We would really appreciate if you would take the time to fill it out. Your input is vital in helping shape future CHAMPS trainings. So as a reminder, our next event, Engagement and Issue Advocacy for O&E staff, will take place on Thursday, August 18th at 11 a.m. Mountain Time or 12 p.m. Central. Registration opens for that event next week. Thank you and have a great afternoon. And thank you so much, Sarah.
Thanks, Sophie.